All right, everyone, we're going to get started here with Grand Rounds. Thank you for coming today, and it really is my pleasure to introduce our Grand Round speaker for today, Dr. Justin Ryder. Justin is my postdoctoral fellow, finishing up his 2-year fellowship. Justin got a master's degree in exercise physiology at the University of Missouri, and then after that went to Arizona State University where he got his PhD in the School of Nutrition and Health Promotion. About 2 years ago, in May of 2014, he started as a postdoctoral fellow with my group, and he was funded through the Minnesota Obesity Prevention Training Program, or the MINOP. Some of you are probably familiar with that. That's through our School of Public Health and Epidemiology. Bob Jeffrey was the PI on that T32. Within probably days or even before you physically came here, Justin started working on his own, writing his own individual postdoctoral fellowship grant for the NIH, which he successfully competed for in his first submission, and that is still funded by the NHLBI. So that was a great accomplishment. In addition to that, he has been really active in grant writing over the last couple of years. He notably received a CTSI Translational Development Research Award, which is a competitive award to receive. Internally, he received one of our Winefest Discovery grants, and both of those grants provided him supplemental funding to enhance the work that he was doing on his NHLBI-funded postdoctoral fellowship. He's been very productive in the last 2 years since he's been here. He has published 10 papers, 4 as first author. He has another 7 that are currently under peer review. 2 and probably 3 are close to being impress. 2 of those, both of those he's first author on, the ones that are about to be impress, one at JAMA Pediatrics and one at the Journal of Pediatrics. He has presented his work at the Obesity Society Annual Scientific Sessions, the American Diabetes Association Scientific Sessions, the American Heart Association Epidemiology Meeting, and then coming up in May, he has an oral platform presentation at the International Congress on Obesity in Vancouver. Justin was the gold medal winner at our press event last year. He's also going to be an oral presenter this year for the best. He won the award last year for the best postdoctoral presentation. He has peer reviewed for 11 journals over the last couple of years, and is currently writing his first independent grant, an R21, that's going to be submitted for the June deadline. This is the kind of guy I think that we want to try to keep around, and in fact, we're talking about that right now. So as I was looking in preparation for this, my notes, I was actually looking at 2 years ago, Justin and I sat down with a piece of paper where I kind of laid out goals and expectations. You know, what are we going to do over the next 2 years? And really looking at it this morning, he's accomplished every single one except for giving a grand rounds, and that's why he's doing this today. I'm actually really proud of this guy. He has worked really hard, and I think his productivity speaks for itself. He's going to spend the next about half hour, 40 minutes talking to you guys about not only what he's been up to with me and others over the last couple of years here, but more importantly, what his plans are going to be for the coming years. So the title of Justin's presentation is Upping the Intensity, Future Innovations in the Fight Against Pediatric Severe Obesity. Justin, you're on.
All right. Can everybody hear me? Thanks, Aaron, for the too nice of an introduction, as is his style. I appreciate the opportunity to come speak with you today and share some of the research that I've done here at the University of Minnesota, and really share with you a lot about what I plan to do in the future, the near future and beyond. So I'm going to spend the... it didn't advance. There we go. So I'm going to kind of break down my talk into 2 different things. The first thing I'm going to do is I'm going to talk about severe obesity in the context of cardiovascular disease and talk about how severe obesity in childhood impacts cardiovascular risk, not only in childhood, but also from a life course perspective, how this could heighten risk into adulthood. And then really I'm going to shift my focus to what do we do about this? What do we do about these severely obese kids with heightened risk factors, and how do we reduce risk? And I take this from an approach that there's no one treatment option really that we have currently available that is better than others, and really that we need to look at all available treatment options in order to target specific children for certain risk factors, because not every child is going to fit into one bin. So these are prevalence data from NHANES, and what these show is that in class 2 and 3 obesity, which is what we define as severe obesity, they're the bottom two lines on this graph. And if we look at the prevalence rate of severe obesity, it's slightly increased over the past 10 years to about a prevalence rate of about 6% in the US pediatric population, 2 to 18-year-olds. If we extrapolate that out to current census data, that's about 4.4 million children in the United States that have severe obesity. And we define severe obesity as an absolute BMI of 35 or as 120% of the 95th percentile, which most people don't really understand because it's pretty complicated, but there's new growth curves that are out for severe obesity. So there's a lot of kids within the United States that have severe obesity. But if we look at this from a different perspective, taking economic data from Finkelstein and colleagues, they suggest that the average lifetime cost of an obese child above that of a normal weight child is about $19,000 per year. So if we take the $19,000 and we multiply that by 4.4, the lifetime cost of just the severely obese children in the United States today, above that of the normal weight children that we have in the US today, is about $85 billion, or about 2.5 years of the US NIH operating budget right now. But you know, that really doesn't tell the whole story, because that's likely an underestimate, because that's based on data for obese children and not exclusive to severe obesity. So it's likely a lower figure than we're actually going to see. So what this really suggests to me is that not only is severe obesity a significant public health challenge, but also it's a significant economic burden. We need to figure out a way to treat it. I think everybody in this room can appreciate that there's numerous health consequences that are associated with obesity. But my lab and my research is primarily focused on cardiovascular disease and cardiovascular risk. You know, why are obese children at higher risk for cardiovascular disease? It's really a question that I'm interested in understanding. But I'm also interested in developing a tangential line of research that looks at fatty liver disease and looks at how ectopic fat distributions within the liver drive cardiovascular disease, and I hope that that's something from a research perspective that I can bring to the University of Minnesota. So why do we want to study cardiovascular disease in the context of pediatric severe obesity? These are seminal data from the Bogalusa Heart Study, and I think they demonstrate a really clear relationship in terms of traditional cardiovascular disease risk factors being heightened in the context of excess adiposity or higher adiposity levels. So these are traditional cardiovascular disease risk factors: HDL, LDL, triglycerides, total cholesterol, insulin, systolic and diastolic blood pressure. And what we see is that normal weight children, so these kids that are under the 84th percentile, there's very few of them that exhibit 2 or more cardiovascular disease risk factors. So we go up to overweight youth, 85th to 94th percentile, about 20% exhibit 2 or more cardiovascular disease risk factors. But as we go up to obesity, which is 95th percentile, we see that about 40% of them exhibit 2 or more cardiovascular disease risk factors. But for each BMI percentile increase beyond that, it's a nice linear increase till we get to 99th percentile, which used to be the traditional severe obesity percentile used, that about 60% of them exhibit 2 or more cardiovascular disease risk factors. And this holds true whether we look at these traditional cardiovascular disease risk factors or something like oxidized LDL, which is a non-traditional marker of cardiovascular disease risk. We see that youth with increased adiposity levels, EO in this case, or extreme obesity, which is the same thing as severe obesity, these individuals have higher levels of cardiovascular disease risk factors. And then if we shift from kind of a traditional lab, from biomarkers to functional measures of physiology, and we look at a measure of arterial stiffness within the carotid artery, we see that youth with severe obesity at all ages have much higher arterial stiffness, which is indicative of poorer cardiovascular function than their normal weight and overweight counterparts. So really what this suggests to me is that if we're going to try to reduce cardiovascular disease risk in youth, we should really be targeting youth with severe obesity, because this is where the risk factors are most pronounced. And another big problem with severe obesity is that it tracks very, very strongly into adulthood. And again, these are seminal data from the Bogalusa Heart Study. And I like to use this as an example because I think it shows this relationship very clearly. There's some other data out there that support these same numbers, but they use adulthood, and they define adulthood as a mean age of 27. So it's really young adulthood. And what they observed is that 100% of youth that had severe obesity as children below the age of 18, when they were 27 years old, they were a mean age of 27, 100% of them were obese as adults. So what that suggests to me is that if you're severely obese as a child, more than likely you will be obese as an adult. But 88% of them had class 2 obesity, or a BMI of greater than 35 as an adult, and 2 out of 3, or 65%, were morbidly obese as adults. So not only do we have a heightened risk factor profile in youth with severe obesity, but the likelihood of them remaining obese for the remainder of their lives, if not severely obese for the remainder of their lives, is very, very high. So we need to figure out some treatment solutions that go beyond just weight loss, but focusing on these risk factor reductions, because more than likely, we're not going to be able to move this benchmark very far. And so I'm going to just explain a few techniques because I think it's important to kind of understand the context of the data that I'm going to go over in a little bit. So one of the techniques that we use in our lab is called flow-mediated dilation. And flow-mediated dilation is a non-invasive way of looking at a brachial artery within the arm and looking at how it functions. And we can stress the artery and look at the response of that artery. So what we do is we take non-invasive ultrasound and we find the brachial artery within a child. We have nice ultrasounds here at the U, and they can allow us to get a pretty picture, a nice window into what that vessel looks like. And then what we can do is we can stress that artery to see how that artery functions under a well-characterized physiological stress. So what we do is we can measure the diameter of the artery, and then what we do is we put a blood pressure cuff on the child's forearm. We pump that blood pressure cuff up to about 200 millimeters of mercury, and what this does is it induces ischemia in the lower limb, or a deprivation of oxygen. With that deprivation of oxygen, the muscle is going to want to have blood flow go through it in order to get that oxygen back to the tissue. So what happens is when we release the cuff after 5 minutes, we get what's called a reactive hyperemic response, or a very substantial increase in blood flow through the arm. What this causes in the conduit vessel, which is the brachial artery, is a lot of shear stress. Shear stress rubs along the endothelial cell surface, and what this causes is an increase in nitric oxide to be released. Nitric oxide is a potent vasodilator, and what we can do is we can measure the diameter change that occurs in the artery. The more diameter change that we get, the healthier the artery is. We can also look at structural measures of vascular physiology within the carotid vessel and look at the intima media thickness layer within the carotid vessel. Greater intima media thickness is a predictor of cardiovascular events in adulthood, and it is indicative of a subclinical atherosclerotic process. But we can also look at this in a functional way within the carotid vessel as well by looking at changes that occur during the normal cardiac cycle between diastole when the arteries are smallest and systole when the arteries are largest. And we can look at the diameter changes that occur during a normal physiological cycle that don't occur under stress conditions, and this can be indicative of arterial stiffness. The greater the stiffness of the artery is also predictive of cardiovascular events in adults. So we have lots of non-invasive tools at our hands to kind of get a window into some of the subclinical processes of atherosclerosis in children, and we're able to do this throughout all age ranges. We can do this as young as 6 years old, so it really gives us a really powerful tool into some of the cardiovascular physiology of young children. And so what I did in collaboration with Julia Steinberger when I first came here was I was really interested in the question of, all right, if we separate adiposity out into different categories, and we look at this in a multitude of ways, if we look at it on basis of BMI, if we look at it on the basis of body fat, if we look at it on the basis of visceral fat, do we see the same relationship with these measures of subclinical atherosclerosis? And then further, what really hasn't been shown is, does insulin resistance using a gold standard measure of hyperinsulinic euglycemic clamp also show a similar relationship? And so what we have here is data that we published later in 2015 was we looked at CIMT, so the thickening of the carotid vessel wall. The thicker the artery, the more indicative of greater atherosclerosis risk. What we observed is that obese children had greater thickening within the carotid vessel wall, greater cardiovascular disease risk than their normal weight counterparts. And that insulin-resistant individuals, those with low MLBM or greater insulin resistance, had greater thickening within the carotid vessel wall. And this has been shown before, except for the clamp data. That was new. But we also showed the same exact relationship in terms of body fat and in terms of visceral fat. So individuals at the highest level of adiposity have the highest cardiovascular disease risk. And so what this suggests to us is that obese youth, regardless of if we determine it by BMI, body fat, or insulin-resistant youth, have greater cardiovascular disease risk by this measure of subclinical atherosclerosis. But really the question to me becomes, these are cross-sectional data, and even though it's a really large cohort, it was 252 kids, what's the trajectory? So this is even a larger cohort. This is an N of over 500, and we don't see necessarily this same relationship. And this is one of the problems with cross-sectional data, is that when we look at this, youth at severe obesity at the youngest ages, and like I said, this total N is a little over 500, so it's not exactly a small sample size, youth with severe obesity have smaller CIMT, and I really don't understand why this is. And we're not the first ones to show this. Elaine Urbina has data in kids with type 2 diabetes, and they show the same trajectory. At young ages, individuals at the highest adiposity level, at the highest risk, have lower CIMT, which is indicative of better or less cardiovascular disease risk. And so it's counterintuitive to what we think. But as we can observe over time, as aging occurs, their CIMT goes up, and the slope or the trajectory of that line is much higher in youth with severe obesity. So really, if we take this and we look at adult data, and this is, again, another data set from one of Julia's cohorts. This is adults and children. This is an N of about 900, about 600 adults, about 300 kids. We can see that clearly, as aging progresses, CIMT, or cardiovascular disease risk, is going to go up. But what we don't know from a longitudinal perspective is what predicts youth that follow a normal trajectory versus what predicts youth that follow an adverse trajectory. Why are some youth going to have heightened cardiovascular disease risk, and why are some youth going to have normal progression over the course of aging? We don't really understand that question, so that's why longitudinal data are really necessary. So I have an F32 right now, thankfully, from NHLBI to really look at this. And so what we're doing is we're measuring children at baseline, and then we're measuring them at 3 years later, and we're measuring every cardiovascular disease risk factor that we really can have our hands on to try to answer this question, to understand what is this trajectory and what is predicting it. So I have a little bit of data, so I can show you. I'm kind of excited to see this. So this is just about 20. I know it's a little bit messy, just got it last week, so you can forgive me a little bit on the cleanliness of it. But what we see is the red triangles and the red lines are youth with severe obesity. And you can see they start lower, but the trajectories are much heightened. They are, at 3 years later, they're going up to right where we're seeing the normal weight youth and the overweight youth where they were starting. So again, we're seeing the same relationship. I don't know why youth with severe obesity is starting lower and have this heightened trajectory, but I think we can observe pretty clearly that their trajectory is not what you would like to see. You don't want to see a slope going up. And we're seeing a normal trend towards an increase. That's a normal product of aging. But what's driving these severely obese kids to have a much more heightened trajectory? We don't really know that answer. And so that's one thing that some of the longitudinal work that I'm going to be doing here hopefully will answer. And then if we shift and we go from a structural measure and we look now at a functional measure of physiology, looking at flow-mediated dilation, the first technique that I showed you, we see a paradoxical relationship where we see that youth that are obese and overweight have better vascular function. The endothelium in these individuals, by this measure, is functioning better than their normal weight counterparts. And we show this from BMI status, and not shown here, we see the same thing with body fat percentage. We see the same thing with visceral fat measured by CT. Individuals with the highest adiposity have the best vascular function measured by FMD. But we also see something completely different when we look at insulin resistance from a hyperinsulinic euglycemic clamp, that there's no relationship between FMD and insulin sensitivity or insulin resistance measured by a hyperinsulinic euglycemic clamp. And these data are not without controversy. There was a nice editorial that was written about this paper that was published along with this to say, maybe we should back off saying that this is vascular protection, that potentially this could be a measurement error problem, because the data on FMD is showing that with increased adiposity, we have better vascular function is counter to about a decade's worth of literature suggesting the exact opposite relationship. So I need to maybe tell you a little bit about why our study is different and I think better. Is our sample size is about 5 times larger than all those other studies. We account for pubertal maturation, which none of the other studies accounted for, but we also account for changes or differences in brachial artery diameter at baseline. And the reason why that's important is the bigger the brachial artery is, the less shear stress is going to be moving through that. Since shear stress is our force that's going to be driving some of the nitric oxide that's going to be fueling some of the vasodilation that's occurring, if you don't have as much shear stress because the vessel's bigger because of obesity, then you're limiting kind of the stressor, if you will, of the response. So we adjusted for brachial artery diameter, which is statistically and physiologically appropriate, and none of those other studies did that. So I think that this is real physiology that's going on. So really the question becomes is, if this is not an issue with measurement, then why are we seeing this? Why are we observing obese children to have better vascular function when everything else we're measuring says the opposite? And so I think this really has to do with insulin, the role of insulin. And so I'm going to do some molecular mechanisms. Just bear with me. I know this probably is going to be really boring, but if we look at the FMD procedure and we look at shear stress, which is our mediator of vasodilation, what it does is it induces L-arginine to be converted to nitric oxide by endothelial nitric oxide synthase, an enzyme, in the endothelial cell. And what nitric oxide does is when it goes to the smooth muscle, it's a potent vasodilator. It causes relaxation of the smooth muscle. Well, insulin does the same thing. If insulin touches the endothelial cell, there's an insulin receptor on the endothelial cell. It activates a cascade of events that induce eNOS to stimulate the production of nitric oxide. We also have another action of insulin, and so this needs to be taken into account. It also triggers a MAP kinase-dependent pathway, which produces a potent vasoconstrictor called endothelin-1. Endothelin-1, when it goes to the smooth muscle, causes vasoconstriction. So in a healthy endothelial cell, you have a balance of insulin's actions between the production of nitric oxide and the production of endothelin-1. This helps regulate vascular tone. So these, in theory, should be in balance. But if you have a healthy endothelial cell and you have youth that are severely obese, they have hyperinsulinemia. If we're taking the assumption that the endothelial cell is still healthy, they're going to have heightened production of nitric oxide. And this potentially could be one of the reasons why we're observing better vascular function in these kids, is because they have much, much higher insulin levels than their normal weight counterparts at baseline. And so they're favorably producing more nitric oxide. They have better nitric oxide bioavailability because this pathway is preserved. But we know that in adulthood, this pathway is no longer preserved. Endothelial cells become insulin resistant. This has even been characterized in cohorts as young as 25 to 30. And so this MAP kinase pathway takes over. So where does this change? When do we start to see youth that are having a protective response due to insulin shift towards a very deleterious response, or a response that causes endothelial dysfunction? We don't know that because nobody's followed kids long enough to be able to tell that. And so it's one of the things that I hope to be able to do. And so another question is really these measures that I just detailed to you, they don't really translate very well to the clinic. They're cumbersome, they require special equipment, special technicians, and they're very, very challenging to put in the context of a clinical setting and really actually help us predict risk within children. So I really want to bring biomarkers of cardiovascular disease risk, novel markers of cardiovascular disease risk to the forefront within the research, and really to help answer three basic questions. One, can we use biomarkers as predictors of longitudinal change? Can we use biomarkers to help us understand some of the differences and discrepancies that we're observing in terms of vascular structure and function? Can these be explaining things that obesity may not be able to explain? Can we use them to help us understand some of the underlying biology? And really, the biggest question for me is, can we find some better biomarkers that readily translate to the clinic that we can use to enhance risk stratification beyond what we already have? And so our lab's already starting to do some of this work, and a few of the markers that we're looking at are really prevalent within the adult realm, but I'm trying to bring them down to pediatrics, bring what's state-of-the-art in the adult world to pediatrics. So one of these markers is circulating endothelial cells. Circulating endothelial cells are sloughed off endothelial cells. They're indicative of endothelial damage, and they circulate within whole blood. And we can measure these. We have a collaboration with Bob Hebbel's lab to measure these, and it's ongoing right now. We're also going to be looking at endothelial microparticles. Endothelial microparticles, we can measure them using flow cytometry. And what endothelial microparticles are is they're a process, they're from a process called endothelial blebbing. It's basically when the endothelium becomes denatured or a non-rectangular shape, it needs to figure out a way to get back to that. And so what it does is it spits off these extracellular vesicles that just happen to be of endothelial origin or endothelial microparticles, and they float around within the circulation. They're pretty small. They're about 100 to 1,000 nanometers in diameter. We can also, another area that we're getting into is looking at microRNAs. So microRNAs are small, non-coding sequences of RNA. They're about 20 nucleotides long. And a lot of the adult literature and animal work suggests that they may be mediators of some of the vascular processes that we're seeing, better vascular function or increased vascular thickening. And so we're going to be measuring microRNAs in two different ways. One, we're going to be measuring them in whole blood using next-generation sequencing to look at them in a discovery project and relate them back to our structural and functional measures, our non-invasive measures of vascular structure and function. But we're also going to measure them within endothelial microparticles. So endothelial microparticles, since they're extracellular vesicles, carry microRNA along with a whole host of other things inside them. So a collaboration we have with Chris D'Souza at University of Colorado Boulder, we are measuring microRNAs within endothelial microparticles to have a endothelial specific measure of these microRNAs. And a new collaboration I just developed, and I think we just came to an agreement last week, is to use metabolomics, to look at serum metabolites, both within urine and within plasma, and see how they relate back to vascular structure and function. Metabolomics has been used for several years now in Framingham, and they've put out several papers now to show that there are several serum metabolites that are predictive of cardiovascular events in adults, but nobody's really looked at this in kids, so that's what we're going to do. And so we have an ongoing longitudinal study. It's about 30% complete. And really, the primary aim of this project is to examine the time course of vascular function and see how adiposity impacts it. And really to characterize some of the longitudinal adaptations that occur in youth, because we really don't know. We're also going to look and see how CECs and EMPs predict changes that occur in subclinical atherosclerosis in terms of CIMT. And then we're also going to do some cross-sectional analysis to look at microRNAs both within EMPs in circulation as well as using metabolomics to look at how they relate to vascular structure and function. And what I'm hoping to do is package all of this data together, both the longitudinal data as well as the novel cross-sectional data, into an R01 that hopefully will be ready to submit by next summer. And so now I'm going to shift my focus onto, all right, we have these kids with high cardiovascular disease risk. We have lots of obese kids. What do we do with them? It's great to characterize risk and to understand the physiology, but we really need better treatment strategies because right now we don't. And so I think the baseline approach for pediatric weight management and the first line of treatment is lifestyle. I think lifestyle management should be given to all overweight and obese children, and lifestyle has many benefits, and a lot of these benefits can be observed without clinically meaningful weight loss, especially in youth with severe obesity. So if you give them lifestyle, there are many benefits, and these include, but aren't limited to, quality of life, depressive symptoms, self-efficacy, executive functioning, school achievement, body composition changes, insulin sensitivity, glycemic status, blood pressure, vascular health, lipids and lipoproteins, novel markers of cardiovascular disease risk, physical function, fitness, dietary quality, and sleep quality. So I give you a laundry list because just to say that lifestyle doesn't necessarily fix things is probably an incorrect assumption. It may not be fixing what you're looking at, but lifestyle does a lot of different things, especially for youth with severe obesity, and a lot of them are non-weight related. Lifestyle interventions really are not good at weight loss in youth with severe obesity, but there are a lot of different factors that can be impacted by using lifestyle intervention. So my area of interest is cardiovascular disease risk, and so when I was a PhD student, I had the fortunate opportunity to work on a lifestyle intervention in Latino youth and obese Latino youth that are really at high risk from a cultural standpoint and ethnicity standpoint for developing type 2 diabetes. So it's a diabetes prevention program in obese Latino youth. It's a 12-week lifestyle intervention, 180 minutes a week of actual physical activity, forced physical activity, not told to do physical activity, and an hour a week of nutrition education with a bilingual, bicultural individual. And I could give a whole presentation on that intervention, but I'm not going to do that. But what we observed was 12 weeks after the intervention, these individuals didn't really lose any weight. Their BMI alters slightly because that's the beauty of working with kids, because they grow as part of normal growth and maturation. That's why BMI shifts, but their weight really stays the same. And I mean, it's a lot of physical activity that they're getting. But what we observe is in these traditional cardiovascular disease risk factors, about a 31% reduction in triglycerides, about a 13% reduction in total cholesterol, and about a 16% reduction in LDL. Now, this is also observed in the presence of not really high values to begin with. So lifestyle is good at reducing cardiovascular disease risk in individuals that are at high risk for developing type 2 diabetes, which is a cardiovascular disease risk factor in my mind, without really having substantially high values to begin with. We also observed in the same intervention that we get a shift to a more favorable lipoprotein profile. And what you really just need to know is that bigger LDL particles and more cholesterol within large HDL particles is indicative of better cardiovascular function. And we want larger LDL particles because they're less prone to oxidation and less prone to getting in the subendothelial space. And that's exactly what we observed, was increases in LDL particle size and a redistribution of cholesterol to be within large HDL particles. And, you know, this is important because the larger the HDL particle is, the less prone it is to become oxidized. And there's two things within a LDL particle that can become oxidized. You can have either the ApoB molecule, the ApoB100 molecule, become oxidized, or the phospholipid bilayer. If one out of the two gets oxidized, it becomes minimally modified LDL, and if 2 out of 2 get oxidized, it becomes fully oxidized LDL. And the problem with oxidized LDL is it gets eaten up in the subendothelial space by macrophages or scavenger receptor CD36, and it spurs foam cell development. So you really don't want that. It's bad. And so what we also observed is serum levels of oxidized LDL concentration. 14 out of 15 of these kids had a decrease in their oxidized LDL levels, suggesting from an overall profile perspective, not only do we have reductions in traditional lipids, but also these non-traditional risk factors are also decreasing with lifestyle, without weight loss in obese kids. So then if we shift our focus now to something that produces substantial weight loss, bariatric surgery, really the question becomes is, what changes do we see with these kids. And so I've been really fortunate to work on the Teen Lab study, which is a prospective, multi-center observational study of 242 kids who have undergone elective bariatric surgery. Mean age is around 17. Mean BMI is around 53. They could get one of three procedures. They could either get gastric bypass. About 160 individuals got gastric bypass. They get sleeve gastrectomy. It's about 67. And then there's a handful, 14 or 15, that got the lap band procedure. And bariatric surgery, this is published in New England Journal in November, produces substantial weight loss, about 30% weight loss at 1 year, and at 3 years that is maintained. I can tell you they've been following these kids for a mean of about 7 years now, and these data look very, very similar. Good sustained effects, and they have really excellent follow-up in Teen Labs, about 90 to 95% retention at most time points beyond even 3 years. That's what happens when you pay them a lot to come back. But what I was interested in, what I broached the question to Tom Inch, who's the PI of this, is what other changes are occurring. So I was fortunate for them to allow me to work on one of the sub-aims of this project, which was to really look at some of the cardiovascular changes that occurred within the context of a functional mobility test. And so a paper that I have under review right now that I think hopefully will get into JAMA Pediatrics was really looking at this question: is what are some of the changes in heart rate response that occur post-bariatric surgery, and what happens to functional mobility in these kids? So I'll just give you a glimpse of the data. So this is heart rate, resting heart rate. So this is how I'll present all the data. We have baseline, 6 months post-surgery, 12 months post-surgery, 24 months post-surgery. And what we see is with resting heart rate, they start out at a mean of around 82, and post-surgery we get a substantial decrease in resting heart rate to about 10 beats per minute after 1 year. That's a substantial reduction in resting heart rate. I would beg to say that that's probably clinically meaningful. Then we also gave these individuals a 400-meter walk test. It's a corridor walk test, so it's a distance, not a time, that they have to complete. They're motivated to try to complete the test as fast as they possibly could. And we measured heart rate using a heart rate monitor during the test, measured post-test heart rate as well as their recovery heart rate post-test. And what we observed is that after surgery, they were able to complete a 400-meter walk test substantially faster, about 30 seconds faster at 6 months, and those improvements were sustained at 1 year and 2 years post-surgery. These were adjusted for baseline BMI as well as a whole host of other factors, but what these suggest is that bariatric surgery is allowing these kids to move substantially faster. Whether or not that means anything to you, for me, what that suggests is that these kids can move the same distance 30 seconds faster. That's 1 lap around a track. That's probably very, very meaningful for a kid that's probably been very limited in their mobility for the rest of their life. I think most of us probably take for granted what walking around 1 lap of the track is, but for a severely obese child, it's a very difficult task. And to be able to do that same task 30 seconds faster is probably very important. So then we were interested in what are the heart rate responses. Do they have to elevate their heart rate substantially higher to actually complete that same task? Well, the answer to that question is no. So this is post-test heart rate. Immediately after their test, what does their heart rate look like? And what we observed was a substantial decrease at 6 months and a further decrease at 12 months that was sustained at 2 years in their post-test heart rate by about 20 beats per minute. So what this suggests is not only are they able to complete the same task faster, 30 seconds faster, but they do not need to elevate their heart rate to the same degree to complete that same task in a lesser amount of time, 20 beats per minute less. So that's pretty substantial in my opinion, because what it suggests to me is that they don't even have to exert themselves as much to complete the same task. It might be indicative of better fitness, but it's not really a fitness test. But what we can suggest is that the functional mobility of these children is better. And then also we can measure what happens in recovery as an indicator of how the heart rate responds. And what happens is post-surgery they have better heart rate recovery. So post 400-meter walk test, let them sit down for 2 minutes and then measure their heart rate again. And what we observe is that their heart rate recovers substantially faster. There's some people that believe that this is a pretty good indicator of fitness. I won't go that far, but what I will say is that these are some substantial adaptations that are occurring, and they are while they're in the presence of substantial weight loss, we looked at the interaction and the association with weight loss, and there's no association between weight loss. So there's something that surgery is doing to drive some of these changes that may be independent of the effects of substantial weight loss. Not shown here, they also had substantial improvements in their musculoskeletal pain at 6 months, 12 months, and 24 months. So bariatric surgery is doing a lot more than just helping these kids lose weight. And so one thing that our group is really focused on is, all right, let's try to find a happy medium between lifestyle, which is great at reducing some risk factors, but the sustainability is questionable, and it doesn't produce great weight loss, and bariatric surgery that is a life-saving procedure for some of these kids, but it's also a life-altering procedure for some of these kids, carries a substantial long-term risk profile, but also it's really a substantial undertaking that most kids not only are not ready for, but they don't qualify for. So really, I think pharmacotherapy gives us a bridge to bridge that gap between these two therapies that work well for certain things but not others, to help us achieve better success for risk reduction in youth with severe obesity. And so I'm really interested in taking this into the context of non-alcoholic fatty liver disease. And while at the U we have great clinical expertise in fatty liver disease, I think we can do a little bit better job, especially within the obesity realm, of adding this into our studies and really ramping up our expertise in this area. And I'm really interested in how fatty liver disease or ectopic distributions of fat in the liver don't drive? Sorry. What's going on? It's not working. Maybe now? Oh, got it. Figured it out. Excellent. Thanks. I'm really interested in how ectopic distributions of fat in the liver drive cardiovascular disease. So, we measure BMI, we measure body fat, but we don't really quantify the fat in the liver very well and see how that exacerbates cardiovascular disease risk. There's a lot of data in kids to suggest that ectopic distributions of fat in the liver drive type 2 diabetes risk, but we really haven't expanded that to look at cardiovascular disease risk and do it well. And we're really well positioned to do that here at the U because we do such a great job at understanding cardiovascular disease, and we do such a great job of characterizing obesity. And all it really takes is a good MRI to be able to answer some of these really important questions. So it's really what I hope to be doing over the next couple of years, is really adding this to our research portfolio and answering some of these questions. But also treatment. From a treatment perspective, we really need to start thinking about fatty liver disease because it could be driving a lot of diseases that we're seeing that are associated with obesity. 60 to 80% of youth with severe obesity have non-alcoholic fatty liver disease, measured by the gold standard, which is liver biopsy. And of those 60 to 80%, 20 to 30% of them are going to end up developing NASH, which is going to not only increase their risk for potential liver transplantation in the future, but also cardiovascular disease and type 2 diabetes. And 20 to 30% of the kids that develop NASH will end up developing cirrhosis. We have no treatment for any of these. We have no treatment for reducing non-alcoholic fatty liver disease. We have no treatment for NASH. And once kids get cirrhosis, you're going to end up having to do liver transplantation, or they're just going to die. This might seem like trivial amounts, but if we take the 4.4 million kids that have severe obesity, if let's just say the small number, 60%, so that's 2.5 million that have fatty liver disease, and 20% of those, so that's 500,000 that would have NASH, and then if we take 20% of those, that's 100,000 kids that will end up needing liver transplants due to cirrhosis. I don't think we have enough livers to go around. So I think we need to do a better job at trying to figure out some treatments for non-alcoholic fatty liver disease before it gets to that point. And so a drug that I'm really interested in looking at, that I've been trying to get funded in this area for about a year now and been unsuccessful, but I'll be successful eventually, is looking at sodium glucose cotransporter 2s, or SGLT2 inhibitors. There's 3 SGLT2 inhibitors that are approved for the treatment of type 2 diabetes in adults. They show pretty good efficacy as a monotherapy, but also as an add-on treatment to metformin. And what SGLT2s do is they inhibit the SGLT2 enzyme or protein within the kidney. And SGLT2 in the kidney regulates about 90% of glucose reabsorption within the kidney. So if you inhibit SGLT2, what happens is you get glucosauria. You get increased glucose excretion within the urine. And so that's why it's a pretty effective strategy for reducing A1C in adults with type 2 diabetes, because they end up urinating out anywhere between about 150 to 400 kcals a day of glucose. It's substantial glucose load that's being removed from the body and not being reabsorbed. And so I'm really interested in looking at this in the context of fatty liver as well as obesity, because it has all these other potential downstream effects. And I say potential is because it's only been studied in the context of type 2 diabetes. Nobody's really looked at it in a healthy, well, I wouldn't call it healthy. Nobody's looked at it in the context of an obese population or an obese population with fatty liver disease. You get substantial reductions in plasma glucose and a corresponding increase in glucagon with a reduction in insulin. Get some weight loss in these individuals. And in animal models, there's 3 or 4 animal models now that have shown that you get a reduction in liver triglycerides, liver weight, as well as some lipid droplet changes that occur. So potentially it could be a novel pharmacotherapy target for reducing not only weight in youth with severe obesity, but also looking at it as a treatment for fatty liver disease where we don't really have anything. Another really interesting thing with SGLT2 inhibitors is it's the first type 2 diabetes drug that's shown to be superior to placebo for reducing cardiovascular events. The first type 2 diabetes drug to show so. So it has a lot of downstream effects, and we think that this is because of its blood pressure lowering properties as well as its ability to reduce arterial stiffness. So there's a lot of effects of SGLT2s, and one of the nice things about them is they have a really low safety profile or a very low adverse event profile. Their safety profile is pretty good. The biggest adverse event that you get with them is urinary tract infections. And there's some ketoacidosis in individuals with type 2 diabetes, but it's like 0.01% of the population, and I hope that our normal glycemic kids won't get ketoacidosis, but you never know until you try. So what I've been proposing for about a year now, and I'll be submitting this as a R21 in the fall, is to do a 6-month randomized controlled trial that's placebo-controlled of an SGLT2 inhibitor called empagliflozin that's made by Boehringer Ingelheim plus lifestyle modification. We're going to try this in 40 adolescents with obesity but that have elevated liver enzymes, and then we're going to leverage the MRI Institute that we have here at the U, and we're going to measure liver fat content in these individuals. A liver fat or a hepatic fat fraction of greater than 5.5% has been shown to be a pretty good marker compared to liver biopsy, which is the gold standard of diagnosis of non-alcoholic fatty liver disease. So we're going to take obese kids with non-alcoholic fatty liver disease, and we're going to put them on this drug for 6 months and see what happens. So our primary outcome is safety. I think any pharmacotherapy trial, really any trial that's going to be above lifestyle, your primary outcome measure should always be safety. If they're not safe, we shouldn't be using them. But if it's safe, we're also going to look at liver fat content changes, and since they all have fatty liver disease, we can look at it in a defined way. We'll also look at weight loss efficacy, because in adults, the studies suggest about 3 to 4% weight loss. And then we'll also look at some of the cardiovascular effects, roll in some of the biomarkers that we've been working on into this trial. So again, hope to have that out for the October deadline as an R21. So just to talk about some future avenues where my research is going to kind of finish up here with the last minute that I have, is that for the summer R21 deadline, we'll be submitting an R21 that's, I didn't do it. There we go. Looking at GLP-1 receptor agonists and how they reduce liver fat content. And so we have Aaron has a R01 right now that's looking at GLP-1 receptor agonists. So we're going to tack on MRI liver fat measures to that study to see how GLP-1 receptor agonists change and alter liver fat content in youth with severe obesity. And really, the hope with that is that if we were to measure it within the context of SGLT2 inhibitors and GLP-1 receptor agonists, potentially looking at a combination therapy down the line of those two drugs as a treatment for non-alcoholic fatty liver disease. But that's like a 5 to 10 year pipe dream. But there's lots of drugs for obesity, but also for fatty liver disease that are in the pipeline that I hope once we start to build this line of research so we can get into. And really, I'm interested in the role of the liver in exacerbating cardiovascular disease risk. I think that just by looking at BMI and just by looking at body fat, we're missing a lot of the contribution that occurs from liver fat. There's good data in adults to suggest that the liver is actually the primary site or drives a lot of the cardiovascular disease risk that we see, but nobody's really done it well in kids, so I plan to do that. And then really, I'm really interested with collaborating with people from all over, both within the U and outside the U, to kind of help with my primary goal, which is to translate biomarkers of cardiovascular disease risk into clinical practice so that we can get better biomarkers into the clinic and we can do a better job of risk stratification. So I'd like to thank my funding sources, a grant from NHLBI, as well as a grant from the CTSA and an internal grant from the Department of Pediatrics Winefest grant, and then I had some subsidies from the Minnesota Obesity Center. Then I've got a laundry list of mentors and collaborators, but I think people get really lucky when they have one good mentor in their life, and I've been fortunate to have two great mentors. My PhD mentor, Gabriel Scheibe at ASU, and my postdoc mentor here at the U, Aaron Kelly. I owe a lot to these guys, and I probably wouldn't be standing here today if it weren't for either of them. So thanks. And I'll take any questions or curiosities, and thanks for listening to me blabber on.
Hi, if you take a non-obese, non-diabetic individual and give them an SGLT2 inhibitor, what happens? Do they get hypoglycemic? Do they excrete more glucose? Since they normally don't excrete any, right? Right.
So it's a great question. There's only like 1 or 2 studies that have done this in their acute trials, done by Ralph DeFranzo. And what they show is that if you put an individual on an SGLT2 inhibitor, and excuse me if I'm saying this wrong because it's not necessarily my area of expertise, but it lowers the dissociation curve. And what happens is if you're on it long enough, they end up actually excreting out glucose, even though their levels are low. And during mealtime excursions where glucose is probably really high, they end up excreting out a lot of that glucose that they get from that glycemic load.
I would think for your grant application, you might want to just do that in a few people just to have a little bit more preliminary data to suggest that the drug actually will do something in someone without diabetes.
That's a great idea. Thanks. Try that.
A question about also the sodium glucose inhibitor, transporter inhibitor. How about the side effect, the common side effect of the glycosuria and polyuria, and especially in pediatric population where their percentage of body, the fluids in the body is, higher in adults? How do you see that as, a side effect? And even also for your research, how would you tease out the weight loss as far as being related to fluid or being actual weight loss?
Yeah, so dehydration is one of the side effects. About 5% experience dehydration. The answer to the question is really don't know until we try, right? So nobody's done a pediatric trial with SGLT2 inhibitors. And so you don't know until you try, but I think we can assume from adult studies that some of the weight loss is going to be attributed to weight loss early, but they have 4-year studies now with SGLT2 inhibitors that show sustained weight loss to 3 and 4 months. The inserts do a really good job of telling kids to remain hydrated, and you don't really have problems with hydration as long as they remain hydrated, but that's definitely an issue with kids and something that we'll have to implement within our design to make sure that they're staying hydrated. Yeah. Curiosities instead of questions?
When we talk about obesity and cardiovascular risk, One of the things which come up is central obesity. Will you be looking into that?
In terms of like waist circumference? Yeah. So it's a good question. So we have the ability to look at visceral fat, and so waist circumference is often used as a proxy for visceral fat when you can't have visceral fat measures. So I'd prefer to look at visceral fat as a measure. I see waist circumference as being a good clinical tool, though, and so there's a lot of literature out on cardiovascular disease risk and waist circumference, but my research is really focused on getting into some better markers. So that's where I think the liver comes into a big role, is we see that central adiposity is associated with greater cardiovascular disease risk. Visceral fat is associated with greater cardiovascular disease risk. Well, maybe it's probably neither of those. Maybe it's fat distribution within the liver that's driving some of those risk factors. No more? Thanks. Got to get a handle on this thing. Kept bumping into this guy. Thanks.
You have been